Hi, good afternoon, everyone. So we'll start on today's lecture. Today's topic for discussion is electrolyte disorders in neurosurgery. So when it comes to neurosurgery, the only electrolyte disorder that we actually care about, or the only electrolyte that we actually care about, is sodium. So we'll be discussing only hyponatremia and hypernatremia. The other electrolyte disorders, as such, are just common to general medicine and don't really have a significant pathology within the neurosurgical field. So we'll only be focusing on sodium for this topic. We'll be covering the lecture in three sections. First, we'll be discussing fluid and electrolyte balance, followed by hyponatremia and then hypernatremia. Okay, so honestly speaking, this topic is slightly complicated, more or less because the practical application of all this knowledge can take a lot of effort. So what we'll try to do is try to make it as simple as possible and just figure out how we can apply all this theoretical knowledge to patients and what we can do with all this information in the real practical scenarios. Right, so first we'll discuss fluid and electrolyte balance. A few simple concepts. Sodium is the predominant solute in the extracellular fluid, and it is the main osmole which is present in the extracellular fluid. So it is what decides more or less what will be the osmolarity of the extracellular fluid. Now, any changes in the serum sodium is going to lead to changes in the osmolarity of the extracellular fluid. And when there's changes in the osmolarity, there are going to be changes in cell volume. The changes in cell volume more or less are important within the brain because it is a constrained compartment, and that is what leads to symptoms. Let it be either hypernatremia or hyponatremia. That is why plasma sodium is going to be tightly regulated, and sodium levels in the body depend on four variables. These are levels of arginine vasopressin, the ability of the kidney to respond to these levels. Also, apart from these two things, intact thirst and access to water. So, if a patient has all these four things being normal, the sodium levels should be normal. Any change in any of these four will lead to abnormalities of serum sodium. Now, the sodium levels by the body are maintained in a very narrow range, and that is controlled by an osmostat. So rather than the serum sodium, it's actually the serum osmolarity which is controlled by the osmostat. And since sodium is the most important osmole in the body, indirectly it is controlled by the osmostat. Now the set point for the osmostat is around 280 of serum osmolarity, and it tries to regulate it within a range of about 280 to 285. Anytime the serum osmolarity goes higher or lower, the osmostat is activated and brings it back to that level. Right? So that is done by release or by decrease in the release of arginine vasopressin. So if your osmolarity goes up, your arginine vasopressin levels will go up. The kidneys will retain free water, and then that will bring down the osmolarity back to the set point. Right? On the right hand side, we can see that this arginine vasopressin will regulate the osmolarity of the urine to bring the set point back. So osmolarity of the urine can vary from as low as 50, that's the most dilute urine you can have, to as high as 1200, so that's the most concentrated urine you can have. The thing with this osmostat is that this slightest variation, if you go slightly below 280 to slightly above 285, will cause the largest variation in the urine osmolarity. So if you have a slightly higher osmolarity, the urine will become maximally dilute. It will become less than 100 osmolarity. So the changes in the urine osmolarity have to be significant to bring about changes in the plasma osmolarity. Right, so the set point, as we discussed in normal individuals, is between 280 to 285. And whenever there's altered osmolarity, the arginine vasopressin levels will change, and that will alter the osmolarity of the urine. And this can range from the most dilute, which is at 50, to the most concentrated at 1200. And this is highly sensitive, as we saw. Even a slightly altered value will cause a maximally dilute urine, for example. And anything less than this extreme response is actually considered inappropriate. So if you have a slightly high plasma osmolarity, for example, if it's 290 to 295, and you're not putting out a urine which is of an osmolarity of less than 100, that is actually an inappropriate response. Right. So, when it comes to sodium and its disorders, it's important to realize there are two different concepts here. The one is the concept of volume, which is basically the amount of total fluid which is present in the body, both the extracellular and the intracellular fluid. And the extracellular fluid will also include an intravascular and extravascular fluid. So, the disorders of sodium are actually disorders of water balance, and there's a separate concept of disorders of volume. So you can have a high volume or a low volume in the body and have no disturbance of sodium. So these are hypovolemias and hypovolemias. On the other hand, you can also have a normal volume and you can have disorders of sodium balance. But technically, disorders of sodium balance are actually disorders of water balance. Right? So when we think of hyponatremia and hypernatremia, instead of thinking that there's lesser sodium in the plasma, we should actually be thinking there's more free water in the plasma. Right? So it's important to change the concept of hyponatremia being less sodium in plasma to there being more free water in plasma. So just to remember that these are disorders of water balance. Now, the whole system is more or less tightly regulated, as we have discussed, by arginine vasopressin. But when we consider volume as well, the whole system is also regulated by the renin-angiotensin system. Right? So these systems are interlinked at the level of AVP, and these are both feedback systems. So whenever there is increase in tonicity, the receptors of that is the organum vasculosum or the lamina terminalis gets activated, releases arginine vasopressin. Arginine vasopressin has multiple receptors. The V2 receptor is present in the kidney, and that is what causes free water retention. V1 receptors are present in large arteries, and that is what causes vasoconstriction and will lead to reflex hypertension. Right, so this is the main two roles of AVP, but also increased tonicity will lead to increase in thirst, which will lead you to drink free water and bring down the tonicity back. Whenever, on the other hand, you have decreased effective intravascular volume, that will affect both your baroreceptors and atrial stress receptors, and as a reflex response, you will get increase in angiotensin 2 levels, which will increase arginine vasopressin levels as well as aldosterone levels, and most of these will work to bring back your intravascular volume. Right. Apart from that, the normal water balance is also dependent on how much water intake there is. Right. So water intake can, or basically the amount of water being produced, can be the amount of water that you take in, the amount of water that is present in food, and the amount of water being generated by metabolism. And the body will put out this water in multiple different ways. Obviously, the renal output. Apart from that, you have something known as the obligatory renal output. That is basically 500 ml for more or less anyone, because that is the amount of free water you require to put out whatever waste you have generated. So that is the obligatory renal output. Apart from that, output is put out into through the skin, through the respiratory system, and through the feces as well. Right, so as we discussed, AVP secretion is influenced both by hypertonicity, but as we also saw, it's also influenced by hypovolemia. So there are two stimuli predominantly for secretion of vasopressin, hypertonicity and hypovolemia. But between these two, hypovolemia is a stronger stimulus for for the release of arginine vasopressin as compared to hypertonicity. So even if a patient has hypotonic plasma but is hypovolemic, they're going to release arginine vasopressin. Right, so as we can see, in a patient who is normovolemic, this is the threshold for release of arginine vasopressin. But as the patient loses volume and becomes hypovolemic, the threshold for vasopressin secretion actually goes down. So just important to remember that a patient might be hypotonic but still have high vasopressin levels because they might be hypovolemic as well. Right, so with this background, we'll discuss further on as to what hyponatremia and how we evaluate and manage hyponatremia. Right, so hyponatremia, the most common cause that you would come across in neurosurgery patients is going to be SAH, but apart from that, there are multiple other causes of hyponatremia. Now, hyponatremia can actually be hypotonic, isotonic, or hypertonic. Right, so that is when the evaluation of plasma osmolarity comes in. Now, as we have already discussed, the most important osmol in plasma is sodium. So we are expecting that a patient who is hyponatremic will also be hypotonic. So it's very weird that a patient who has hyponatremia should be isotonic or hypertonic. So let's see when that happens. Now, a patient may be having isotonic hyponatremia when it is a lab artifact. So this is also known as pseudo hyponatremia. And this happens because of the chemical test being affected by either very high triglyceride levels or because of some abnormal proteins being present. So technically, there is no change in the tonicity and there's no change in the actual levels of sodium. And so isotonic hyponatremia has no clinical significance. You might also have something known as hypertonic hyponatremia, and that is because there's a presence of effective osmoles other than sodium within the within the plasma. So these are usually glucose, mannitol, or glycerol, right? So this on the other hand, unlike isotonic hyponatremia, is important because the plasma is hypertonic, and because of which you can get cellular dehydration. So which is something we are not expecting with hyponatremia, but because this hyponatremia is occurring secondary to hypertonicity, that is why it is causing cellular dehydration. The most common type of hyponatremia on the other hand is hypotonic hyponatremia. And that, as we have already discussed, is rather than being a deficit of sodium, is actually because of excess free water in the plasma. Right, so the first thing we do when we have a patient with hyponatremia is we go in and we measure the serum osmolarity levels. Right, so sodium is less than 135. We'll go and measure the osmolarity, and we evaluate to see whether the patient is hypotonic, isotonic, or hypertonic. Right, so if the patient is isotonic, we know that it is most likely pseudo-hyponatremia, and that's nothing for us to worry about. Most likely they have some abnormal proteins or high triglyceride levels. The other thing that can happen is they could have hypertonic hyponatremia, and then we have to check for glucose levels and whether we have given them mannitol or not. Or most likely they have hypotonic hyponatremia. Right, so this what we need to do to check specifically if a patient has hypertonic hyponatremia is figure out what is the actual value of serum osmolarity as measured by the lab, and what is the estimated serum osmolarity. Right, so serum osmolarity, if only normal osmoles are present, would be estimated by this formula: 2 into the sodium levels in the blood plus glucose levels by 18 plus BUN by 2.8. Right, so if your measured osmolarity actually exceeds its estimated osmolarity, there are excessive effective osmoles which are present in the blood. Most likely this will be mannitol because glucose levels are still measured with this osmolarity equation over here. Another approach to hyponatremia, rather than the one we discussed, where it's classified into isotonic, hypotonic, and hypertonic, is to classify it by the primary mechanism which is causing hyponatremia. To understand this, we have to understand that hyponatremia can either be happening because of changes in the free water levels within the body, or because there's a change in the effective osmol level within the body. Now, basically any product which does not any compound which does not cross the cell membrane easily is called an osmol. Now, if it is able to at least slightly cross it easily, it's called an ineffective osmol. Like urea would be an ineffective osmol. It will drag water along with it, but it is still able to cross the cell membrane. On the other hand, osmoles which cannot cross the cell membrane easily are known as effective osmoles. So sodium and glucose are all effective osmoles. Right, so your hyponatremia can happen either because of changes in the free water levels or because of changes in the osmoles. So this could happen either because there's a lot of free water which we have taken inside the body, or the amount of free water being put out by the kidneys is not enough. So the causes of increased free water intake could be polydipsia, or the patient has been given hypotonic fluids like 5% dextrose, or because of water being retained during surgical irrigation. They could also have decreased free water outputs, that is SiADH. Also in some other condition where the water output has gone into other compartments of the body rather than going out of the kidney itself. So these include heart failure, liver disease, sepsis, hypothyroidism, where the effective intravascular volume has come down even though the patient has a normal body volume. The other causes of hyponatremia, on the other hand, could be because osmol intake or osmol output altering. So if you have decreased effective osmol intake, as would happen in malnutrition, or you are losing osmoles in the fluid from somewhere. Now that fluid loss could happen through the kidney, or it could happen outside the kidney as well. So the important cause here would be cerebral salt wasting syndrome, But apart from that, you could also be losing osmoles when you have hypocortisolism, hypoaldosteronism, and hypothyroidism. So these are the important causes to remember in this case. So that is when we want to discuss a concept known as free water clearance. Okay, so that will help us decide what is the type of hyponatremia and how to evaluate and manage this hyponatremia. Right, so free water clearance is basically the amount of electrolyte-free water that is being excreted by the kidney. Right, so the urine volume that is put out by the kidney consists of two components. One part of it is isotonic to plasma, and one part is completely free of any electrolytes, and then that is known as free water, also known as electrolyte-free water. Right, so the amount of electrolyte-free water which is put out by the kidney is known as electrolyte-free water clearance. When the electrolyte-free water clearance is positive, then free water is being put out by the kidney. And when the electrolyte-free water clearance is negative, then free water is being retained by the kidney. So how can we estimate what is the electrolyte-free water clearance? So basically that depends on what is the levels of osmoles which are present in the urine as compared to that in the plasma. So basically the amount of urine which is completely electrolyte free is estimated by this formula. So 1 minus the urine concentration of sodium plus the urine concentration of potassium divided by the plasma concentration of sodium. Now if these two are equal, it means you're secreting urine which is completely isotonic to plasma and there's no electrolyte free water clearance. Now if the urine sodium and potassium is low, that means you're secreting urine which is hypotonic to plasma and you have a positive electrolyte free water clearance. On the other hand, if this is higher than the sodium levels in the plasma, it means it's secreting a concentrated urine and your electrolyte-free water clearance is negative. Similar to electrolyte-free water clearance, we also have intake and balance. So the electrolyte-free water intake, again, is similar to the concept of whatever is the clearance by the kidney. Again, how much is your sodium and potassium intake compared to that of the levels in the plasma? Right, so this is the amount of free water that you're taking into your body. Now, electrolyte-free water balance, on the other hand, is basically the electrolyte-free water intake, and it should just be the electrolyte-free water clearance that should be subtracted from that to get the electrolyte-free water balance. But it's important to remember that the body also generates free water through normal metabolic reaction, so that gets added to your free water intake. And there are also some insensible losses of free water which happen in sweat, in the GI tract, and in through the respiratory tract, and that also needs to be subtracted to get the total electrolyte-free water balance. Okay, so just the basic idea is that if your electrolyte-free water balance is nil or it is zero, your water intake, which is free of electrolytes, is equal to your water output. And in that case, your sodium levels should not change. So, if a patient does have hyponatremia and you evaluate their electrolyte-free water clearance, and if you find that this electrolyte-free water clearance or free water clearance is positive, that means that the kidneys are putting out free water. And if they are putting out free water, then that means that the hyponatremia should resolve because the kidney is getting rid of all that excess free water which is already present and causing the hyponatremia. On the other hand, sometimes in a patient with hyponatremia, the electrolyte-free water clearance can be negative. And that means that the kidneys itself are the problem. They are retaining free water and they are creating the problem. So in that case, we can help improve the electrolyte-free water clearance by increasing it with AVP antagonists. On the other hand, we can also try to reduce the intake of electrolyte-free water by making it negative by restricting either free water intake or using salts to convert free water into either isotonic or hypertonic fluid. Right, so when we're evaluating a patient with hyponatremia, one thing we saw was we evaluate osmolarity levels and then we go ahead from there. Another thing we can do is try to figure out what is the primary mechanism which is causing that hyponatremia. To do that, as we saw, we need to figure out if the patient has a positive or a negative electrolyte-free water clearance. The only thing which matters there to figure out is whether the urine electrolytes are lesser or they are more than the sodium levels within the plasma itself. So if your urinary sodium and potassium turns out to be lesser than that in the plasma, there could be two reasons for that. If it is much lesser than that in the plasma, that is actually appropriate for tonicity. Because remember, you have hyponatremia and you want to be putting out incredibly dilute urine. So that means that you would be having very low levels of urine, sodium, and potassium. That means your kidney is working to improve the status of hyponatremia. So in that case, there would be three causes for what is the reason for hyponatremia. Either you have lost the solute somewhere else apart from the kidney, or you're not taking in enough solute, like as in malnutrition, or you have taken in a lot of water, as in primary polydipsia. On the other hand, if in hyponatremia, you have the urinary sodium or potassium being slightly low or even equal, or actually higher, that is inappropriate for that. Because as we know, that a patient who has hyponatremia should be putting out the most dilute urine. So if they're not doing that, that means it is inappropriate for tonicity, and that means something is wrong. And most likely the problem is at the level of the kidney. Right? So the problem in this case could either be because of hypovolemia, SIADH, or renal salt wasting. Right, so how can we differentiate between these three causes? So that is when AVP levels come in. Now, AVP levels are going to be elevated both in patients who have hypovolemia and SIADH. In patients with SIADH, this is being inappropriately put out by the hypothalamus or the pituitary. On the other hand, in patients with hypovolemia, this is appropriately elevated because you want to retain volume. And we know that the strongest stimulus for AVP release is hypovolemia. Now, how do we differentiate between these two? And why is it important to differentiate? Because if you give volume replacement to a patient with hyponatremia, with hypovolemia, that hyponatremia will improve. Okay, now that's where we have to understand how this hyponatremia has happened. In a patient with hypovolemia, they're going to be so if a patient has hypovolemia, they're going to go ahead and they're going to release AVP, as we know. Once they release AVP, that is going to go and act on the kidney, and that is going to retain free water. And since it is retaining only free water, it is going to lead to hyponatremia. Now, if you do volume replacement with whatever, okay, and you restore this volume levels to normal, if the patient becomes euvolemic, they stop releasing AVP and they stop retaining free water, and the hyponatremia will come to its normal levels by itself. There's no need for 3% NS or any other treatment in these patients. On the other hand, if you do a volume replacement in patients who have SIADH, it will actually worsen hyponatremia. And the reason why this happens is we are assuming that this volume replacement is being done with 0.9% NS. Okay, and this or normal saline. So the thing with normal saline is when you have very high AVP levels, your AVP will act on the kidney, and it will, whenever it is excreting this particular product, it is just going to withdraw free water out of it. Okay, and that process is known as desalination. So basically, but whatever normal saline you give gets desalinated and gets converted to free water. That free water gets added to the body and actually ends up worsening hyponatremia. Right? So volume replacement will make things better in patients who are hypovolemic, but on the other hand, volume replacement with normal saline in patients who have SIADH will actually worsen hyponatremia because the kidney desalinates this normal saline, converts it to free water under the high levels of AVP, and further adds to your excessive free water which is present in the body already. On the other hand, free water restriction will improve SIADH but obviously worsen hypovolemia. So it's very important to differentiate between these two conditions. Now, how can one differentiate between the two? Well, you can go ahead and you can measure the urinary sodium levels. Now, the urinary sodium levels actually can be low or high in patients with hypovolemia. If they are low, that effectively rules out both SIADH and cerebral salt wasting and rules in hypovolemia. Right? So if the sodium levels are less than 20, it means that the problem is high because of hypovolemia. And in that patient, you can just go ahead and do volume replacement without having to worry about any problems happening. Right. But this urinary sodium levels can be high also in hypovolemia. Okay. That is because of high AVP levels. Right. You can get low sodium levels on the other hand when there is not enough blood flow happening to the kidney for the kidney to generate that level of sodium. Right, so when on the other hand there's a high AVP level in patients who have hypovolemia, they can also still get an elevated sodium level as well. So this elevated sodium level can happen in patients with cerebral salt wasting as well as SIADH. So you cannot use the urinary sodium levels if it is elevated to differentiate between these conditions. When that happens, on the other hand, you can use the fractional excretion of sodium instead. right? So the fractional excretion of sodium basically measures how much amount of sodium are we putting out as compared to creatine. So if the body is trying to retain sodium, the fractional excretion of sodium will come down. On the other hand, if the body is trying to particularly put out sodium, the fractional excretion comes up. Now, in patients who have SIADH, because they're trying to retain free water, the fractional excretion can be slightly high or even maybe normal. But because the patients in cerebral salt wasting, they are putting out high levels of sodium in the urine, the fractional excretion of sodium will be high in these patients. On the other hand, patients who have a low or ineffective intraarterial volume, who just don't have enough volume to reach the kidney also, they're going to have a low excretion of sodium because there the body is trying to retain sodium because there will be hyperaldosteronism. The amount of sodium which is put out in the urine will be much lesser. So if your fractional excretion of sodium is less than 0.5%, that indicates most likely you have a low intraarterial volume, and in those patients you can go ahead and give normal saline without any concern. On the other hand, in patients with SIADH and CSWS, the fractional excretion of sodium will be more than 0.5%, and that's where you need to be a little bit more careful about giving normal saline. Right, so we'll just go through a flowchart will help us figure out exactly what we should do with these patients. So when there's a patient who has low levels of sodium, so these are some things which we have not yet discussed, but some of these things we cannot even do in our own labs. What we need to do, a lot of these labs, they evaluate these sodium levels with indirect electrodes. So and that can actually lead to low errors in sodium when there are paraproteins or when there are high triglycerides levels which are present. So instead, if you evaluate them with direct electrodes, you can actually figure that out, and you can realize that the problem is because of pseudo-hyponatremia. And that's when you need to consider serum protein and albumin and lipid levels as the problem and correct that instead. On the other hand, if you have proper hyponatremia, the patient needs to be evaluated with daily weight checking, and whatever is the input-output balance needs to be checked on a daily basis. You also need to get the plasma osmolarity, as we've discussed, the serum electrolytes and the renal function checked, followed by checking the urinary sodium and potassium. You also want to check the glucose levels to make sure that high levels of glucose are not causing the problem. Right? Once you have done all that, you also want to check the plasma osmolarity and evaluate whether it is the same as what you estimate. What would be the estimated osmolarity? As we've already discussed the equation for estimated osmolarity, we need to compare both of these and check that. So if the plasma osmolarity is much higher than the estimated osmolarity, there is some effective osmo which is present, which is not accounted for. So that usually might be mannitol or glycerol, right? So that we need to check for that and then correct that accordingly. Right, so once we have ruled out hypertonic and isotonic hyponatremia, we're only left with isotonic hyponatremia. For evaluation of isotonic hyponatremia, as we saw, we need to figure out whether the kidney is putting out more free water or it is retaining free water. So to do that, we have to look at the levels of urinary electrolytes as compared to plasma electrolytes. If the levels of urinary electrolytes are higher, that means that the kidney is retaining free water. And in a patient who has hyponatremia, if the kidney is retaining free water, that means that the problem is with the kidney, right? So in that case, the renal output is actually worsening the hyponatremia. Now, there are two different ways that this could happen. It's either because the kidney is retaining free water or the kidney is wasting salt, right? So as we saw in a patient where the kidney is retaining free water, your Fe sodium is going to be normal to high, right? And the other condition where the kidney could be retaining free water apart from SIADH would be, as we saw, hypovolemia. So in patients with hypovolemia, your fractional excretion of sodium is going to be low. So that is how we can differentiate between those two. On the other hand, in renal salt wasting, you're going to have a high Fe sodium and a high output of urine sodium as well. The only problem that arises is how do we differentiate between patients who have SIADH and patients who have cerebral salt wasting. The thing with this is that it can be very difficult to differentiate between both of those things. With both the conditions, you will get high levels of urinary sodium. You're going to get high fractional excretion of sodium. The only thing is that in cerebral salt wasting, the patient will be hypovolemic. Now, sometimes the patient can be obviously hypovolemic and have tachycardia and hypertension, but sometimes they might not be so obviously hypovolemic, right? So in that case, you'd have to go in and measure the pulmonary artery pressure or the central venous pressure to be able to get a clearer idea. Sometimes you can get a slight idea even from hematocrit levels. If the hematocrit is elevated, that could also point you in the direction that it might be cerebral salt wasting as compared to SIADH. Right. On the other hand, if the sodium and potassium in the urine is lesser than the sodium in the plasma, it means that the kidney is putting out free water and it's actually trying to help the hyponatremia. Now, so the reason why hyponatremia has developed is actually not because of a problem in the kidney, it's because of a problem elsewhere. So there are three ways that can happen. It could either be because you have lost solute elsewhere. It could be because of GI loss or loss in the blood or loss of blood, sorry, or because of burns, or you have taken in a lot of free water. Okay, so that could be because of psychogenic polydipsia, or it could be because you're not taking enough solutes. Okay, so that will also lead, for example, that would be from malnutrition. So in all these patients, you're going to get a low output of electrolytes in the urine, but you'll also get a low excretion of sodium as well. So that, as we discussed, can seem slightly complicated. The basic idea basically boils down to this: if your sodium levels are low, get the osmolarity checked. Okay, rule out both hypertonic and isotonic hyponatremia. Once you know it is hypertonic hyponatremia, go in, check the urine osmolarity levels. If the urine osmolarity is very low, most likely the patient has primary polydipsia. On the other hand, if the urine osmolarity is high, which is abnormal, a patient who has hyponatremia should not have a high urine osmolarity. That means that something is wrong with the kidney and there's an impaired diluting capacity. Right? So once you know that it is hypertonic, hypoosmolar hyponatremia, you have to go in and check what is the ECF volume. Now, if the ECF volume is depleted, the problem is hypovolemia. Sometimes the ECF volume can be increased, so this would indicate edema states like congestive heart failure or cirrhosis, where the volume has moved out of the vasculature but is still within the body. But if the ECF volume is normal, the most likely cause is SIADH. But there could be some other causes which also need to be ruled out. The most important causes being lack of cortisol and lack of thyroid in the body. Apart from that, sometimes the patient is on thiazide diuretic that can also mimic an SIADH. Right, so that is how we evaluate a patient with hyponatremia. Now, once a patient with hyponatremia does come in, how do we manage them? Now, a hyponatremic patient could be symptomatic or could be asymptomatic. Now, if a hyponatremic patient is symptomatic, the treatment directly is using hypertonic solutions. There's nothing else to worry about over there. If a patient is symptomatic because of hyponatremia, go in and give them 3% NS. Right, so the treatment apart from this of giving hypertonic solutions could be you try to increase their free water clearance, decrease their free water intake, or increase their free osmol intake. Right, so all of these are basically also trying to again target hyponatremia by changing the water balance. So we'll discuss these as we go on. Right, so when it comes to symptomatic hyponatremia, not all patients who have hyponatremia are going to be symptomatic. The most important factor would be the rate at which the osmolarity has fallen. Now, if it has fallen very quickly, that is most likely when they're going to be symptomatic. On the other hand, if it's been present for weeks to months, even patients with the 110, 115 sodium might not be symptomatic. When the sodium levels fall below 125 is usually when they become symptomatic, and at the beginning they have anorexia, nausea, and malaise. When it falls between 110 to 120, the symptoms get slightly more serious and they start developing headache, confusion, and slight deterioration of sensorium. And below 110, they can develop seizures and coma. The cause for all of this is because they're hyponatremic, they are hypoosmolar. So they have a lot of free water, it goes into the brain and causes cerebral edema. Right, so as we discussed, if the patient is symptomatic from hyponatremia, because of the hyponatremia itself, you have to treat it urgently with hypertonic saline, regardless of whatever is the cause of hyponatremia. Why not normal saline on the other hand? Because as we have already discussed, if the patient has SIADH, or any cause where there's high ABP levels, that normal saline will be desalinated and converted back to free water by the kidney, and then it will be returned back to the body and will further drop your sodium levels. Okay, so if a patient has hyponatremia, which is symptomatic, how much 3% saline are we giving them? What is the rate of correction? So there has been a lot of debate about this previously, but the recent guidelines say that you can give 3% saline as a bolus directly if the patient is symptomatic, as a bolus of 100 ml over 10 minutes. Once you have done that, you take a sample and send it for evaluation by the lab. And after you have taken the sample, you can repeat it again. Okay, so these two boluses together are supposed to raise the levels by at least 5 millimole per liter immediately. Apart from that, the other general rules of treatment of hypernatremia will also apply. On the other hand, if the patient is asymptomatic, there's no need to give them 3% NS unless it is indicated. So we'll come to those indications. But if the patient is asymptomatic, the first line treatment is usually going to be free water restriction. Okay, and we have to understand the concept of free water restriction. The point is to restrict free water, not to restrict water as such, right? So if a person on the other hand is getting water with salt in it, that is not free water, right? So restricting free water is different from restricting water, right? So free water restriction is what is usually required for all patients with SIADH, and usually with free water restriction, the hyponatremia will resolve. On the other hand, if the patient has hypovolemia, cerebral salt wasting, or any intracranial catastrophe like SAH or TBI, you want to usually avoid fluid restriction in those patients. So if the patient only has SIADH for whatever cause, you go ahead and restrict the free water. On the other hand, if the patient is hypovolemic, has cerebral salt wasting, or any intracranial problem, usually avoid restricting fluid. In these patients, treatment can be done with isotonic saline on the other hand. This works to actually restore the volume first predominantly, okay, and then also bring down the AVP levels once the volume is restored. The additional effect, if just treatment with isotonic saline is not working, additional effect can be taken on with free water restriction, increased effective osmol intake that can either be done with salt tablets or hypertonic saline infusion, or mineralocorticoids like fludrocortisone. Now, in patients with chronic hyponatremia, how would we infuse 3% NS? On the other hand, the basic idea is that 3% NS has an osmolarity of 513. So what we can do is to figure out how much 3% NS we need to infuse to get the target change in P sodium. We can use this formula. The important thing to remember is that we want to get a serum sodium change of less than 10 millimoles within 1 day, right? So first, the formula is quite simple. It is a target change in sodium into the total body water divided by the osmolarity of the fluid we're using. Since it is 3% saline, it's going to be divided by 513. Total body water can be measured as 0.6 into body weight for men and 0.5 into body weight for women. Once you get the total volume of 3% saline you have to use, you can divide it by 24 and get the hourly rate of 3% saline infusion. Whenever you are treating a patient with something which is supposed to change the sodium levels, you have to monitor the sodium levels at least every 4 to 6 hours during treatment to adjust the rate of correction. Now, how much correction can be done in a day? The usual cutoff is about 10 millimoles per liter per day, but it is not as easy as that. The main concern as to why we are even worried about this is obviously osmotic demyelination syndrome, and that is usually seen whenever you correct more than 10 millimoles per liter per day. Usually occurs at 1 to 10 days after treatment and can obviously cause irreversible neurological deficits. The important thing to know is what are the risk factors for ODS. Any patient who has hypokalemia, malnutrition, alcoholism, or has an advanced age or female gender is actually at a higher risk for osmotic demyelination syndrome. And the reason why we want to know this risk is because that will decide how much sodium we can correct in the first 24 hours. For patients who are at high risk of ODS, we should only be correcting up to 6 millimoles in the first 24 hours. If you're at a moderate risk, you can correct up to 8. If you're at a lower risk, you can correct up to 12 millimoles in 24 hours. Another important thing is that the total correction over 48 hours should not exceed 18 millimoles per liter. Sometimes it does happen that we end up overcorrecting. So in that case, it is important to bring down the sodium levels again, either by using free water or by using arginine vasopressin. So apart from trying to bring up the sodium levels by correcting with hypertonic saline, we can also use other methods to improve the free water clearance. So in patients who have low renal free water clearance, like in SIADH, we could either use loop diuretics or we can use Vaptins to increase the free water clearance. Loop diuretics are a good option and they should be definitely considered before Vaptins. Okay, but the important thing is that they can lead to a risk of hypokalemia. Vaptins, on the other hand, are a dangerous and unpredictable drug. And overall, in the treatment of hyponatremia, they should be used last. There are two well-known Vaptins. Conivaptan is an injectable drug, and it is both a V1A and a V2 antagonist. Because it is a V1A antagonist, it can cause hypotension. It can also cause bleeding, right? Because it affects platelet aggregation. Tolvaptan, on the other hand, is an oral drug, and it is a V2 antagonist, so it does not have the cardiovascular side effects and the bleeding side effects as much. It is safer than conivaptan and can be given orally. The usual dose you want to start with is 15 milligrams per day. On day 2, it can be increased to 30 milligrams per day. Alright, so this is a flow chart for a patient who has hyponatremia. Like, nothing to worry about. We've already discussed all of this. If the patient is symptomatic, you go in and you give them a bolus of 3% NS. Okay, and then you recheck the sodium levels after that. Okay, and you can give up to 2 to 3 boluses of this 3% NS. The point is for there to be at least a 5 millimole per liter increase with these boluses. Once you have done that, usually on that same day, you don't go any further. You can just leave it at that. With that, usually the symptoms itself should resolve. The patient might still have hyponatremia, but the symptoms would have resolved. Once the symptoms have resolved, you can go ahead and start doing a free water restriction and monitor your sodium levels. On the other hand, if the patient is asymptomatic, that's when we need to consider, does the patient have an intracranial pathology or does not have an intracranial pathology. If the patient has an intracranial pathology, remember, we do not usually restrict fluid as much. So whatever is feasible, we will restrict. But the basic idea in patients with intracranial pathology and asymptomatic hyponatremia is to give them normal saline as a maintenance fluid to maintain the volume state. If that does not work, you can give them salt tablets or a hypertonic saline infusion. On the other hand, if the patient does not have any intracranial problems, then we have to go in and measure the free water clearance. This would help. If the free water clearance is more than 750 ml, we can restrict the free water intake to 750 ml. If the free water clearance is less than 750 ml, we can restrict the free water intake to 500 ml. Remember, we cannot go below 500 ml because at least 500 ml of free water is required to generate urine for waste purpose. If in patients who are asymptomatic, who have no intracranial problems, fluid restriction does not work, you can use salt tablets, you can use loop diuretics as we discussed, you can use Vaptins. Right, so that is all about hyponatremia, a slightly confusing topic, but I think if we go through these flowcharts, it is a little bit easier and helpful to remember. Right, so now coming to hyponatremia, this is a much easier and simpler topic to understand. Right, so hypernatremia, the most important thing to remember in hypernatremia is that a normal patient who is awake, who is conscious, even if they have diabetes insipidus, is not going to develop hypernatremia because the thirst mechanism is going to make sure that you're taking enough free water to keep the sodium levels normal. So hypernatremia can only occur in patients who cannot take enough free water to maintain the plasma tonicity, regardless of whether they have any other problem or not. Even if they have DI, they're able to take in enough water, they will not develop hypernatremia. So this usually happens only in patients who are incapacitated or have an impaired thirst mechanism because of injury to the hypothalamus, or they just don't have access to free water. So again, even with hypernatremia, the first thing you want to go and do is rule out hypernatremic and hypertonic and hypotonic hypernatremia. So if a patient has hypernatremia and is hypertonic, most likely it has happened because you have given them a hypertonic fluid which contains sodium, like 3% NS or bicarbonate. On the other hand, if the patient is hypernatremic and hypotonic, most likely it's because they have lost fluid, which through the GI, through the skin or through the kidney. On the other hand, most likely what you'll find is that the ECF volume is normal and the patient is isovolemic and has hypernatremia. So in that case, we'll go in and measure the urine osmolarity. If the urine osmolarity is lesser than the plasma osmolarity, most likely they have diabetes insipidus. On the other hand, if the urine osmolarity is more than the plasma osmolarity, they have lost water somewhere else other than the kidney. Right, so similarly as we discussed with hyponatremia, the same concept can apply to hypernatremia also. Hypernatremia can happen either because there's a problem with free water or there's a problem with osmoles. Okay, so just one thing is in hypernatremia, you've either lost free water and that is what is causing sodium levels to be high, or for whatever reason, you've got a high level of sodium itself. Right, so the problem can be because of decrease in the free water intake, as we've already discussed. The patient does not have access to water, or they just don't have a thirst drive. It could also be either because you're putting out a lot of free water. The most important cause would be DI over there, either central or nephrogenic, or you're losing water somewhere else apart from the kidney. Apart from that, you can also have it because you've taken in a lot of effective osmoles, most likely because of hypertonic fluids being administered to you, or your amount of osmoles being put out of the kidney is lesser, as would happen in hyperaldosteronemia and hypercortisolism. Right, so again, just like with hyponatremia, even with hypernatremia, the first thing we'll go in and do is figure out what is the volume status and what is the osmolarity. Once we have come to the realization that it is a euvolemic patient who has hypertonic hypernatremia, we're going to try to figure out what is the cause for that. So to do that, again, we need to estimate what is the urine sodium and potassium levels. Again, remember, if the patient is hypernatremic, they should be trying to retain as much free water as possible and their urine should be very highly concentrated. So we're expecting that a patient who is hypernatremic should have a high concentration of urine sodium and urine potassium. If it is much, much higher than the plasma sodium, it means that it is appropriate for tonicity. For a patient who is hypernatremic, we are expecting the urine to be concentrated and the urine sodium and potassium should be very high as compared to the plasma sodium. So that would be appropriate. And that is when the problem does not lie in the kidney, right? So that could either be because you are not taking in enough water, or you have been given a lot of hypertonic fluids, or you're losing water elsewhere. On the other hand, if a hypernatremic patient actually has less urine sodium and potassium, or slightly more or even equal to the plasma sodium, that is actually inappropriate for a patient who is hypernatremic. Again, a patient who is hypernatremic, we're expecting that they will be retaining a lot of free water to correct the hypernatremia, which means that their urine potassium and sodium should be very high. If it is low or if it is even slightly high, it is inappropriate. That means that the problem is in the kidney, and that is either because you have DI or the kidney is putting out a lot of osmoles because of osmotic diuresis. So again, a similar flowchart. When you have high levels of sodium, you have to repeat the blood tests and check if the high level of sodium is because of pseudohypernatremia or not. Do the same more or less investigations to figure out what is the cause for hypernatremia and how we are correcting it. Again, once you have done that, you measure the sodium levels in the blood and the sodium levels in the urine. If the sodium levels in the urine are much, much higher than that in the plasma, it means that the kidney is trying to help. It is trying to retain free water. It is trying to correct the problem. So that, again, as we discussed, could be either because you're just not taking in enough water, because you don't have access to water, or you have an impaired thirst mechanism, or you're taking in a lot of solute. Okay, somebody's given you hypertonic fluids, or you are losing water somewhere other than the kidney, like in sweat, like in diarrhea, like in respiratory losses. On the other hand, if it is equal, or if it is slightly lesser or slightly more, that means that the kidney is not helping. The problem is at the level of the kidney. Okay, and that could either be because you have diabetes insipidus or you have osmotic diuresis happening. Right, so once we have evaluated what is the cause for hypernatremia, we can go ahead and manage that. So hypernatremia, again, just like hypernatremia, could be symptomatic or asymptomatic. A patient with symptomatic hypernatremia should be treated urgently with free water and vasopressin, right? So most like if a patient is acutely symptomatic, most likely they're going to be in altered sensorium. So you cannot give them oral free water. So you're going to have to give them free water in the form of 5% dextrose, which can be given at the rate of 4 to 6 ml per kg per hour. The other thing you need to do is figure out what is the amount of water deficit. Again, remember, hypernatremia, rather than being a problem of high amounts of sodium, is actually a problem of the lack of free water in the body. So you have to calculate what is the water deficit and try to replace that. So water deficit can be calculated as the total body water into 1 minus 140 by the current sodium values. So that will give you what is the total deficit that the patient has for free water. Right, so if you are using 5% dextrose to correct that water deficit, you don't have to use this formula at all, because 5% dextrose has zero osmolarity. This, once 5D is given to the body, the dextrose is metabolized, so ultimately it ends up just becoming free water more or less. So if you're using 5% dextrose, you don't have to use this equation. You can directly just calculate the water deficit. For example, if it is 500 ml, divided by 24, and will tell you how much should be the rate of infusion of 5D per hour. On the other hand, if you're using any of the other solutions like DNS or half NS, you need to use this formula to calculate what will be the rate of infusion of that. So the basic idea there is you take in the infused sodium levels, which, for example, if you're using half NS would be 77, subtract the serum sodium levels and divide it by the total body water plus 1. That will tell you how much from 1 liter of half NS, how much change in serum sodium would happen. And to get up till 10 ml, 10 milliequivalents per liter change in serum sodium, how much of this half NS you have to infuse. Usually, whatever value you get from this calculation, you have to add about 1 to 1.5 liters to that. That is to correct for the insensate losses and the losses you will be getting through the kidney and the sweat and the lungs as well. Right. So again, with hypernatremia, similar to hyponatremia, is it acute and symptomatic, or is it asymptomatic and chronic? If it is acute and symptomatic, give the patient 5% dextrose immediately. Okay, if it is asymptomatic and chronic, you can wait for some more time. Instead of 5% dextrose IV, we can just give them oral free water instead. There is actually not a very strict cutoff for how much correction you can achieve with hypernatremia as compared to hyponatremia. Still, overall, the suggestion is that try to achieve only 10 millimole per liter in 24 hours, just like the cutoff that we have for hyponatremia. On the other hand, if you figure out that the patient does have diabetes insipidus, you can treat them with vasopressin if it is central DI. If it is nephrogenic DI, vasopressin will not work. An option there would be thiazide diuretics on the other hand. Right, so that is all for a discussion of hypernatremia and hyponatremia in the management of neurosurgical patients. We'll be discussing a few questions, and you can leave the answers to this question in the chat box, and then we'll just go through these. So the first question is, which amongst the following is the strongest stimulus for release of arginine vasopressin? Hypotonicity, hypovolemia, hypertonicity, or hypervolemia? Right, so the answer is hypovolemia. As we have discussed multiple times, the strongest stimulus for the release of vasopressin is hypovolemia and not hypotonicity. Which amongst the following is true? Patients with diabetes insipidus develop hypernatremia. The most common cause of hyponatremia is pseudohyponatremia. Hyponatremia less than 125 millimole per liter should be treated immediately with 3% saline. And a low fractionalization of sodium indicates hypovolemia rather than SIADH. Okay, so patients with diabetes insipidus will never develop hypernatremia unless somehow their ability to retain or to drink free water is impaired. So not all patients with diabetes insipidus have hypernatremia. They're just going to drink free water and maintain those sodium levels. The correct answer is number 4, that low fractionalization of sodium indicates hypovolemia, because in SIADH the urine will be concentrated and you'll be putting out a high amount of sodium. Hyponatremia less than 125 should not be treated with 3% saline. You have, unless the patient is symptomatic, that is the only indication to treat with 3% saline immediately. And the most common cause of hyponatremia is hypotonic hyponatremia, most likely from SIADH. Right. So, which amongst the following is the likely diagnosis in a patient who has the following biochemical parameters? The serum sodium is 125, the serum osmolarity is 260, the urine sodium is 60, the urine osmolarity is 275, the fractionation of sodium is 0.6, and the hematocrit is 55%. Okay, so first of all, the patient has hyponatremia, and as we can see, it is hypoosmolar hyponatremia. Okay, the urine sodium levels are more than 20. So we know that most likely we cannot just simply rule out SIADH and cerebral salt wasting syndrome, right? So the next thing we have to do if urine sodium is more than 40 is come to fractionation of sodium. Now fractionation of sodium is 0.6, so it is more than 0.5, so we're able to rule out hypovolemia. So our only two main concerns are SIADH versus cerebral salt wasting syndrome. The hematocrit is slightly high, it is 55%, so that indicates most likely the patient has cerebral salt wasting syndrome. So the answer for this question is number 2, cerebral salt wasting syndrome. Right, so the last question is, which amongst the following is the last resort in the treatment of hypernatremia? Free water restriction, loop diuretics, salt tablets, and Vaptins. Right, so the answer is Vaptins. They are unpredictable. They can cause a lot of problems. We want to use them as a last possible resort in treatment of hypernatremia. Right, so that is all for today's class. If you have any doubts, you can leave them in the chat box or in the feedback form afterwards.